1, 2,
And review, somebody female.
Oh shit, I got some blood going. Oh, he's wearing it too.
You're in the bay. Once you get over to the bed, we'll give you the story. Everything's going to happen super fast. Welcome to the emergency room.
I lost the pulse.
It's
300 please.
I'll keep you on again.
Pulse check. No pulse.
no more pulse.
Yeah. Here, what do the ECMO people say? And her blood pressure is off the dropping.
45 minutes of CPR and no return of circulation. Okay.
Imagine waking up in the dead of night. You bolt upright in bed, your chest is heaving.
Gripped by just this sheer primal terror.
Right. Because you feel like you are literally drowning. You gasp for air, but your lungs, they aren't filling with oxygen.
They're rapidly filling with your own plasma.
Exactly. You are suffocating from the inside out. I mean, this is flash pulmonary edema, which is the catastrophic climax of a failing heart. And today, we are taking you into the absolute trenches of critical care.
Yeah, our mission for this deep dive isn't to give you some polite textbook overview of cardiology.
No, we are aggressively applying the 80-20 rule here, the Pareto principle, to a massive stack of critical care literature on heart failure. We're isolating the exact mechanisms, the precise physiological dominoes that fall, to completely transform how you look at a crashing patient.
Because we're bypassing the low-yield fluff entirely, when you're standing at the bedside and alarms are screaming, you don't have time to sift through trivia.
You really don't.
You need to know exactly what is failing at a cellular level. You need to know what the immediate threat is and what intervention will pull that patient back from the brink. So we're tracing that unforgiving path from a slowly failing pump to an immediate life-threatening crisis, and finally to the mechanical interventions that keep a human alive when their organs have just surrendered.
Because the goal is to anticipate the pathology before it happens. We want you to think like an elite ICU intensivist.
Which means instantly distinguishing between an issue that can wait for morning rounds and a physiological collapse that will literally kill your patient in the next 5 minutes.
Right, but before we get to the chaos of the ICU, we have to understand the foundation. We have to look at the chronic, insidious progression of a failing heart. Because a patient doesn't usually just wake up in flash pulmonary edema without a whole cascade of cellular and structural failures laying the groundwork over, like, months or years.
That is the perfect place to start. So, the 80-20 overview of chronic heart failure is this. At its absolute core, it's the inability of the heart to provide sufficient blood to meet the oxygen needs of the tissues and organs.
And it's the #1 reason for hospital admission in adults over the age of 65.
Exactly. But to really understand this disease, you have to look closely at who is getting what type of failure, because it is definitely not a monolith.
Not at all.
For instance, men most often present with HFrEF, that's heart failure, with reduced ejection fraction. The pump itself is fundamentally weak, usually driven by ischemic causes.
Like a history of massive myocardial infarctions that left dead scar tissue on the ventricle.
Right, but the literature highlights a massive clinical blind spot here when we look at women.
Yeah, this part is wild. Because women make up 50% of the people living with heart failure, yet they typically present with HFpEF, heart failure with preserved ejection fraction.
Right, so the heart muscle might technically squeeze out a normal percentage of blood, but the ventricles are incredibly stiff and non-compliant.
And shockingly, the sources point out that this is frequently misdiagnosed. There's this lingering, honestly outdated, and incredibly dangerous perception in medicine that heart failure is primarily a male condition.
It's a tragic disparity, because women with heart failure tend to be older than men with the condition, and they often present with a much greater, more debilitating symptom burden.
But because their ejection fraction might look quote-unquote normal on a quick scan, their profound fatigue and shortness of breath are often written off as anxiety or just deconditioning.
And those disparities in health equity, they don't stop there. Black and Hispanic patients develop heart failure at a significantly earlier age.
Right.
They are admitted to the hospital far more often, and they face much higher mortality rates related to the disease compared to white patients. The structural inequities in healthcare directly manifest in these failing ventricles.
Which means we need to deeply understand the pathophysiology, the why behind the disease, so we don't miss it. Let's talk about the mechanics of the heart muscle. In the past, people always used the rubber band analogy for the Frank Starling law, right?
Oh, yeah. You stretch a rubber band, it snaps back harder, but stretch it too much for too long and it gets floppy.
Yeah, but honestly, I think a better way to look at this chronic failure is to think of the body as a failing business.
Okay, a failing business.
A business that starts taking out high-interest payday loans just to keep the lights on.
I love that framework. Let's trace that step by step. The trigger is usually an initial myocardial injury, let's say years of uncontrolled hypertension or a heart attack.
Okay.
This leads to the first physiologic change, a drop in cardiac output. The heart just isn't pumping enough forward volume. Now, the body's various systems sense this drop in blood flow, and they completely misinterpret the situation. I mean, they panic.
Right, they think low blood pressure, low flow, we must be bleeding out in the jungle.
Exactly. The juxtaglomerular apparatus in the kidneys senses the low renal blood flow. So the kidney acts like a panicked middle manager and activates the renin-angiotensin-aldosterone system, or RAAS.
So it dumps renin into the blood.
Yes, which eventually converts to angiotensin II, which is one of the most potent vasoconstrictors in the human body. And at the exact same time, baroreceptors in the aortic arch and carotid sinus sense the low pressure.
So they ring the alarm bell for the sympathetic nervous system.
Right. Flooding the bloodstream with catecholamines, adrenaline, and noradrenaline.
So the body is actively taking out those payday loans. It's clamping down the blood vessels with angiotensin II to raise the blood pressure, and it's whipping the heart with adrenaline to make it beat faster and harder.
And to your point, if you were actually bleeding out from a tiger attack, that is a brilliant short-term survival mechanism.
But in heart failure, there is no tiger.
No, there is no blood loss. And this compensation rapidly becomes the primary driver of decompensation. Chronic exposure to high levels of catecholamines and angiotensin II is literally toxic to the myocardial cells.
Wow.
It triggers myocyte apoptosis. The heart cells essentially commit programmed suicide. It stimulates massive collagen synthesis, leading to dense, rigid fibrosis.
So the heart actually changes its physical shape in response to this toxic bath.
Exactly. It undergoes pathologic ventricular remodeling. The left ventricle transforms from an efficient, muscular, elliptical shape into a dilated, spherical, ineffective, floppy bag.
And the clinical findings are the direct result of this bankrupt system. The pump is spherical and weak, the vessels are clamped down tight, so the blood has nowhere to go but backward.
Right. Hydrostatic pressure rises, and fluid is physically forced out of the veins and into the surrounding tissues, giving us that classic edema.
So when a nurse walks into a patient's room, what is the progression of these signs? Like, what are the early whispers of this process versus the late blaring alarms?
Early on, the very first thing you might see is unexplained tachycardia at rest.
Just a high heart rate sitting there.
Yeah, that is the sympathetic nervous system relentlessly whipping the failing heart just to maintain a baseline cardiac output. You'll also see profound, debilitating fatigue. And a classic early sign that is often missed, nocturia.
Having to pee all night. But why does that happen specifically with heart failure?
Well, it's all about fluid shifts. During the day, gravity pulls all that extra fluid down into their legs and feet. But when the patient lies down flat in bed at night, that massive pool of fluid in the lower extremities shifts back into the central circulation.
Ah, so suddenly the kidneys are getting perfused much better than they were during the day.
Exactly. The kidneys think, great, extra volume, let's filter it. So the patient is up 5 times a night to urinate.
And then we move to the classic signs that everyone learns but really needs to truly understand. Orthopnea and paroxysmal nocturnal dyspnea, or PND.
Yes.
With orthopnea, you can't just ask a patient, are you short of breath? I mean, they might say no because they've adapted. You have to ask them about the mechanics of their sleep.
Right. How many pillows do you need to prop yourself up at night? Or do you have to sleep sitting straight up in your La-Z-Boy recliner just to catch your breath?
Because lying flat spreads that fluid out over their lungs. But PND is even more terrifying.
Oh, PND is the physiological nightmare you described at the very beginning. They go to sleep, the fluid shifts, and the pulmonary vessels become engorged. They wake up a few hours later in a sheer panic, feeling like they're suffocating.
Desperate to sit up or run to an open window for air.
Exactly, because their lungs are becoming congested with fluid. And if the disease progresses past this, we start seeing the late, highly dangerous finding.
Like pulsus alternans.
Yes, where if you palpate their pulse, you feel a rhythm that alternates between a strong beat and a weak beat over and over. It's a sign of profound, severe left ventricular failure. You might also auscultate S3 or S4 heart sounds. And in the most advanced stages, you see cardiac cachexia.
That's a wasting.
Yeah. The patient is experiencing severe muscle wasting and fat loss because their gut is so edematous it can't absorb nutrients, and the work of breathing burns so many calories. But this horrific starvation is often completely masked by their massive generalized fluid weight.
So they look swollen, but they're literally starving to death.
Yes.
To figure out exactly what kind of mechanical failure we're dealing with, we turn to diagnostics. And the literature points to the echocardiogram as the absolute gold standard here.
Unquestionably. The echo is what tells us if we're dealing with a weak pump, HFrEF, or a stiff pump, HFpEF. We look at the left ventricular ejection fraction.
If it's less than 40%, the pump is weak.
Right. But if it's normal, say 55% or higher, but the ultrasound shows these thick, stiff, non-compliant ventricles that can't relax to fill with blood.
That's diastolic dysfunction, or HFpEF.
Exactly. We also rely on blood markers, specifically the BNP and NT-proBNP.
Now, this is where it gets incredibly fascinating. Because these aren't just biomarkers of cellular damage, like a troponin, right?
No, not at all.
These are actually active counter-regulatory hormones.
Oh.
Can you break down what the heart is actually trying to achieve when it dumps BNP into the blood?
Yeah, this is just a beautiful piece of human physiology. BNP brain, or B-type natriuretic peptide, is secreted directly by the ventricles in response to excessive stretching from volume overload.
Yeah.
It is the heart's desperate chemical attempt to fight back against the toxic payday loans. The heart realizes the RAAS system is killing it with volume and pressure, so it releases BNP, which travels to the kidneys and tries to force them to excrete sodium and water.
Which is natriuresis.
Right. It also acts as a vasodilator to open up the blood vessels and lower the pressure.
So when a clinician looks at a lab report and sees a sky-high BNP, they shouldn't just think, oh, heart damage. They are literally looking at the chemical footprint of a heart that is crying out for help. A heart that's stretching to its absolute physical limits.
Yeah.
Trying to forcefully turn off the body's toxic compensatory mechanisms.
Exactly. It's a distress signal. So how do we structure our clinical approach when we recognize this distress? If we think about our ADPI priorities, the very first thing we must assess is whether we are looking at fluid volume overload, the congestion, the crackles, the edema, or if we're looking at dangerously low perfusion.
Right, like cold skin, confusion, low urine output.
Exactly. Our immediate measurable goals are to achieve a realistic balance of activity for the patient and maintain a stable, dry baseline weight.
Which means, as a bedside nurse or an intensivist, you're looking at very specific implementations. There's the teaching side, obviously ensuring they understand strict sodium and fluid restrictions.
Sure.
But the absolute holy grail of independent nursing action here is the daily weight protocol. And I mean rigorous, uncompromising daily weights.
It has to be uncompromising. Same time every single morning before breakfast, same scale, completely calibrated, same amount of clothing. The daily weight is not just a chart filler, it is the most sensitive indicator of fluid retention we have.
It's how you catch a physiological deterioration 3 days before the patient ends up crashing on a ventilator.
Precisely. Let's talk about the clinical priorities. If a new nurse walks into a room and a heart failure patient is reporting increased shortness of breath, what is the literal first move before they even touch the IV pole or look at the chart?
The absolute first move is airway, breathing, and vital signs. You have to assess their respiratory status immediately.
Right. Are they using accessory muscles? Are they moving air? What is their oxygen saturation?
You have to rule out an immediate airway compromise from pulmonary edema before you do anything else.
Exactly. And once you know they are oxygenating, your next T priority is administering the scheduled neurohormonal blockade medications. These are the drugs that literally save their life by stopping the toxic remodeling.
Then you execute those rigorous weight protocols to trend their fluid status.
Let's dive deep into that core arsenal of medications. The pharmacology here is where we actively intervene in that pathological cascade. First up, ACE inhibitors, drugs like captopril or lisinopril.
So ACE inhibitors are a cornerstone therapy. They specifically block the angiotensin-converting enzyme, which stops the conversion of angiotensin I to angiotensin II.
Right, and by doing this, we effectively shut down the most dangerous arm of the RAAS. This massively reduces afterload, the resistance the heart has to pump against.
making it infinitely easier for the weak ventricle to push blood forward.
Exactly. And most importantly, it halts and even reverses that spherical ventricular remodeling.
But the side effects require intense monitoring, right?
Oh, absolutely. You can get severe first-dose hypotension. They can bottom out their blood pressure rapidly when you take away that compensatory squeeze.
You also have to watch potassium levels like a hawk, because blocking aldosterone means the kidneys stop excreting potassium, which leads to hyperkalemia.
And of course, you have to watch for the terrifying allergic reaction, angioedema, where their airway just swells shut.
Right. Next up in the arsenal are the beta blockers. Drugs like carvedilol or metoprolol succinate. Now hang on a second. I have to push back here.
Go ahead.
You're telling me the central problem is a failing pump. The cardiac output is in the basement. The tissues are starving for oxygen.
Right.
And the cornerstone of modern therapy is a drug that literally reduces contractility and slows the heart rate down. I mean, are we trying to finish the job? That sounds completely backward.
It really does.
Why would we put the brakes on a car that is already stalling out?
It is arguably the most counterintuitive concept in all of cardiology, but it is undeniably life-saving. Yes, beta blockers reduce contractility in the short term. They slow the heart down. But remember the payday loan analogy.
Yeah.
Remember what is actually killing the heart muscle over the long term. The toxic bath of catecholamines, the constant whipping of a tired, dying horse by the sympathetic nervous system.
So the adrenaline is causing the apoptosis and the fibrosis.
Precisely. Beta blockers shield the myocardial cells from that adrenaline toxicity. They act as a chemical force field. By forcing the heart to slow down, it decreases myocardial oxygen demand.
Wow.
Over months and years, this protection actually promotes reverse remodeling. The heart rests, it heals slightly, it shrinks back to a more normal shape, and the ejection fraction can actually dramatically improve.
That makes so much sense.
The golden rule, however, is that you have to start low and go incredibly slow. You would never give a massive dose of a beta blocker to a patient in acute decompensated failure who is crashing.
Because they'd code.
Exactly. You introduce it when they're stable to protect the heart for the long haul.
That reframes it completely. You're blocking the chronic damage, even at the cost of short-term output. Then we have the aldosterone antagonists, like spironolactone. We usually just think of it as a potassium-sparing diuretic, but its real magic in heart failure isn't just making the patient pee, right?
Yeah. No, the diuresis is almost a side benefit. The real magic is that spironolactone directly blocks aldosterone from binding to the receptors in the heart muscle.
And aldosterone is a major trigger for myocardial fibrosis, right?
Yes. So by blocking it, we keep the heart muscle from turning into rigid stone.
Then we have the newer heavy hitters, the ARNI sacubitril, combined with valsartan. This is a brilliant dual blockade. The valsartan is an ARB. It blocks the angiotensin II receptors, keeping the vessels dilated. But the sacubitril is fascinating. It inhibits an enzyme called neprilysin.
Right.
Now, neprilysin's natural job in the body is to roam around and degrade our helpful friend, BNP.
Right. So by giving sacubitril to inhibit neprilysin, we are stopping the degradation of BNP. We keep the heart's own natural defense mechanism circulating in the blood much longer.
Allowing the BNP to continually promote diuresis and vasodilation.
Exactly. It's enhancing the body's only good compensatory mechanism while simultaneously blocking the bad one.
And we absolutely must touch on the SGLT2 inhibitors, like dapagliflozin. These were originally developed as diabetes medications, correct?
Yep. Yes, they were.
But they have completely revolutionized heart failure treatment. They block glucose reabsorption in the kidneys, causing this profound osmotic diuresis. Water follows the glucose right out into the urine.
But the wild thing is, clinical trials showed they drastically reduce cardiovascular death and hospitalizations in HFrEF patients, even if those patients don't have diabetes at all.
That's incredible.
It's been a massive paradigm shift. They manage volume beautifully, they lower blood pressure, and they seem to improve myocardial metabolism in ways we are honestly still uncovering. They are essential now.
So those are the chemical interventions. Let's talk about the physical mechanical interventions for chronic failure, specifically cardiac resynchronization therapy, or CRT, biventricular pacing. Walk me through the mechanics of this. How exactly does wiring a pacemaker into the chest fix a failing remodeled heart?
Well, think back to that pathological remodeling. As the left ventricle dilates and becomes a massive spherical balloon, the electrical pathways embedded in that muscle, the bundle branches and Purkinje fibers, they get physically stretched and deformed.
And because they're stretched, the electrical signal takes longer to travel through them.
Yes. And this leads to dysynchrony.
Meaning the chambers aren't firing together.
Exactly. Normally, the right ventricle and the left ventricle contract at the exact same millisecond. But in a remodeled heart, the right ventricle fires first and the left ventricle fires late. The heart develops this incredibly inefficient rolling wobble.
Like a washing machine with an unbalanced load.
That's exactly it. It expends a massive amount of energy but pumps very little blood. So CRT uses a specialized pacemaker with an extra pacing lead. We thread that lead through the right atrium into the coronary sinus and wrap it around to the outside of the left ventricle.
Which allows the device to pace both ventricles simultaneously.
Right. It forces them to squeeze at the exact same time, coordinating the contraction, fixing the wobble, and instantly improving forward cardiac output without demanding more oxygen from the muscle.
It's mechanical elegance. Speaking of mechanics, we need to constantly keep the hemodynamics and respiratory interplay in mind. These terms get thrown around all the time, preload and afterload. How should an intensivist visualize them?
Preload is the volume of blood stretching the ventricle at the very end of diastole, just before it squeezes. It's the physical stretch. Afterload is the resistance the left ventricle must overcome to push open the aortic valve and eject that blood into the systemic circulation.
So chronic heart failure traps the patient in a vicious cycle.
A terrible cycle. They have inappropriately high preload because the kidneys are desperately retaining sodium and fluid. And they have inappropriately high afterload because the sympathetic nervous system is clamping down all the arteries.
The failing, weakened heart is literally caught in a death trap between too much fluid entering and too much resistance preventing it from leaving.
Exactly. And managing that trap requires a delicate balancing act with fluids and electrolytes. We restrict sodium heavily, typically to 2 grams a day, to stop the water retention.
Interestingly, the literature says we don't necessarily severely restrict overall fluid intake unless they're in advanced stage D failure with persistent, uncontrollable retention.
That's right. But the electrolytes, you have to watch potassium like a hawk.
Because it's a constant tug-of-war. The loop diuretics we give to clear the volume will violently deplete potassium, right? Which puts the patient at risk for lethal arrhythmias.
But simultaneously, the ACE inhibitors and the spironolactone we give to stop the remodeling cause the kidneys to retain potassium. The nurse is constantly threading the needle between hypokalemia and hyperkalemia.
And if we fail to balance the system, or if the disease simply overpowers our interventions, we see devastating complications. The two most prominent in the literature are cardiorenal syndrome and atrial fibrillation.
Yeah.
Let's start with cardiorenal syndrome. I mean, this sounds like the organs form a murder-suicide pact.
That is a grim but incredibly accurate way to look at it. In cardiorenal syndrome, the heart is failing so badly that cardiac output drops. Because output is low, renal perfusion plummets. The kidneys start to fail from lack of oxygen, and they double down on the RAAS activation, retaining massive amounts of fluid.
And this extra fluid overloads the already failing heart even further, making it pump worse, which decreases renal perfusion even more.
It is a rapid, inescapable death spiral unless we break the cycle with aggressive diuresis or mechanical support.
And then there's atrial fibrillation. How does a failing ventricle cause the atria to short circuit?
Well, as the left ventricle fails, pressure backs up into the left atrium. The atrium dilates and stretches to accommodate the extra volume. And just like in the ventricles, stretching the atrial muscle stretches its electrical pathways.
So they fray in short circuit.
Exactly. Instead of one coordinated, powerful contraction, the atria just sit there and quiver chaotically.
And why is that so dangerous for a heart failure patient? I mean, don't plenty of people walk around with AFib every day?
Yes, they do. But a heart failure patient relies heavily on something called the atrial kick. The atrial kick is that final, powerful squeeze of blood from the atria into the ventricles right before systole.
And that kick can account for up to 30% of the total cardiac output.
Right. If the atria are just quivering, you instantly lose that 30%. That sudden drop can instantly push a stable chronic patient into acute decompensated failure.
Wow.
Furthermore, because the blood is just pooling and swirling in the quivering atria, it forms clots. Those clots get pumped straight to the brain, leading to massive strokes. The priority action the moment a HF patient goes into AFib is immediate rate control and aggressive anticoagulation.
So, as the bedside clinician, how do we spot the subtle signs of deterioration? What are the trends that tell us the patient is getting worse if?
You're watching for worsening mentation, sudden confusion, or profound restlessness. If they become restless and can't get comfortable, that often means the brain is becoming hypoperfused.
Because cardiac output has dropped critically low.
Yes. You're also watching for a steadily rising resting heart rate. That's the body's desperate attempt to compensate for dropping stroke volume. And above all, you watch the scale.
Right. A weight gain of 3 pounds in 2 days or 3 to 5 pounds in a week. That much weight isn't fab. It means they're retaining massive liters worth amounts of fluid, and they're standing right on the edge of the cliff.
At that point, you escalate. You don't wait for the crackles in the lungs. You notify the provider immediately for those weight trends, for any new reports of waking up gasping for air, or for a dry, hacking cough when they lie down.
I want to emphasize that cough. It's not just a tickle in the throat. A dry, hacking cough, when supine, is an early, critical sign of pulmonary congestion as fluid begins to engorge the pulmonary vessels.
And when you're assessing these patients, you must use intense pattern recognition, but you also have to rule out differentials.
For sure.
If you see an older adult with chronic fatigue and progressive shortness of breath, you absolutely must think heart failure. That's your index of suspicion. But you also have to formally rule out underlying COPD exacerbations or severe anemia induced by chronic kidney disease.
Because both of those can present with almost identical fatigue and dyspnea. Let's hit some critical ICU pearls and exam traps for this chronic phase. What are the things novice nurses or test takers constantly get wrong?
Trap number 1, assuming all edema is heart failure.
Oh, yeah.
Do not blindly assume that bilateral leg swelling automatically means the heart is failing. It could be venous stasis, profound hypoproteinemia where they don't have enough albumin to keep fluid in the vessels, or liver failure. You have to look for the other signs like the JVD or the orthopnea.
And trap number 2, thinking BNP is exclusive to heart failure.
Exactly. BNP is released when the ventricles stretch. A massive pulmonary embolism will cause severe back pressure, stretching the right ventricle and spiking the BNP without left heart failure.
Also, renal failure severely decreases the clearance of BNP from the blood, artificially inflating the lab value even if the heart is perfectly stable.
You must always know the patient's baseline.
All right, let's run this entire chronic phase through our intensivist thinking framework.
Let's do it.
The problem we are facing is decreased cardiac output.
The failing physiology causing it is the neurohormonal toxicity from the RAAS and sympathetic nervous system.
The immediate threat to the patient's life is pathologic ventricular remodeling and lethal arrhythmias from the stretched muscle.
The intervention is aggressive, titrated pharmacology, beta blockers, and ACE inhibitors to block the toxicity.
And the reassessment is long-term, watching for symptoms to resolve and LVEF to actually improve over months on follow-up echocardiograms.
That is exactly how you synthesize the data. So before we move to the absolute chaos of the emergency department, let's lock this down. If an ICU nurse is walking away from this discussion and they can only hold on to 5 absolute core truths about chronic heart failure, what are they?
First, the core pathophysiology is chronic neurohormonal activation, specifically RAAS and SNS, causing toxic, irreversible ventricular remodeling.
Second, the key assessment finding that screams heart failure is orthopnea and paroxysmal nocturnal dyspnea.
Third, the most dangerous complication in this phase is sudden cardiac death from ventricular dysrhythmias, which is exactly why patients with ejection fractions under 35% get implantable defibrillators.
Fourth, the absolute priority independent nursing action is accurate, strict daily weights to catch decompensation early.
And fifth, the most important long-term treatment is the combination of ACE inhibitors and beta blockers to force reverse remodeling.
If you had to distill this entire patient profile into a single sentence, the quintessential picture.
It's an older adult with a history of long-standing hypertension or a previous myocardial infarction presenting with progressive crushing fatigue, exertional dyspnea, and peripheral edema.
And the critical trigger, the if you see X, think Y.
If you see a 3-pound weight gain in 2 days, think massive fluid retention and immediate decompensation and notify the provider for an urgent diuretic adjustment.
Perfect. But as we know all too well, chronic compensation only lasts so long. The beta blockers and the ACE inhibitors buy time, sometimes decades of time, but eventually the disease progresses.
Or, a patient who is barely balanced on a knife's edge eats a bag of salty chips or catches a mild respiratory virus.
And that tiny physiological stressor is enough to tip the scales entirely?
Which brings us to the ICU emergency: acute decompensated heart failure and pulmonary edema. The failing business finally goes bankrupt. The eviction notice arrives. We are shifting from the relatively calm, controlled environment of the outpatient clinic to the chaotic, adrenaline-fueled reality of the emergency department and the intensive care unit.
The 80-20 overview for acute decompensated heart failure, or ADHF, is that this is a sudden, dramatic, and terrifying decrease in functional status that requires rapid, aggressive, and perfectly timed therapy escalation.
And the vast majority of these patients present with a clinical profile we categorize as wet and warm.
Right. They are wet because they are actively drowning in rapid volume overload, but they are warm because, for the moment, their cardiac output is still just barely high enough to maintain peripheral perfusion. Their skin is still warm, their capillary refill is okay, and their pulses are palpable.
Let's walk through the pathophysiology of this acute crisis, step by step, because the speed at which a patient can go from breathing okay to coughing up pink froth is astounding. Why does it happen so fast?
It starts when the left ventricle acutely fails to manage the volume returning to it. It simply cannot pump the blood forward into the high-pressure aorta.
Okay.
Because it can't move forward, the blood rapidly backs up into the left atrium. The atrium dilates instantly, and that massive pressure backs up further into the pulmonary veins, which are bringing oxygenated blood from the lungs.
So the pulmonary venous pressure skyrockets in a matter of minutes.
Yes. This creates massive hydrostatic pressure within the tiny, fragile pulmonary capillary beds. This pressure physically forces the water component of the blood out of the vessels and into the pulmonary interstitium, the tissue space between the vessels and the air sacs.
And the body doesn't just immediately drown, right? The lymphatic system recognizes the fluid and kicks into overdrive to drain it away.
Exactly. The lymphatics in the lungs widen and pump as fast as they can, acting like sump pumps in a flooding basement. And while they are keeping up, the patient might just have a mild cough or slight tachypnea.
But there is a terrifying tipping point.
When that hydrostatic pressure from the failing heart finally overwhelms the maximal capacity of the lymphatic drainage, the fluid has nowhere else to go. It breaches the alveolar lining.
And the alveoli, the millions of tiny air sacs where oxygen exchange actually happens, they rapidly fill with a mix of plasma and red blood cells.
This is flash pulmonary edema. The patient is literally drowning from the inside out in their own serosanguineous fluid. Gas exchange stops.
That is a horrifying clinical picture.
Yeah.
So how does our physical assessment track with this rapid progression?
In the very early stages, when the fluid is just in the interstitium, you might just see mild tachypnea. They're breathing a little faster. You'll see a slight creeping decrease in their PO2 on the monitor and a rising sense of anxiety. They'll tell you they just can't quite catch a deep breath.
But the classic presentation, like the moment they hit the ED doors when the fluid is breaching the alveoli, is unmistakable.
Oh, absolutely. You will see profound JVD jugular venous distension. The blood is backing up so badly from the left to the lungs to the right heart that the jugular veins in the neck bulge out.
And JVD is the single most sensitive and specific clinical sign we have for elevated left ventricular filling pressures.
It is. They will have severe orthopnea, sitting absolutely bolt upright. Their respiratory rate will be over 30, and you will see severe accessory muscle use their neck and chest muscles straining to pull air through the fluid.
And the late, extremely dangerous findings, like when they are minutes away from a code.
Pink, frothy sputum. The fluid in the alveoli mixes with air from their gasping breaths, whipping it into a pink foam that literally bubbles up out of their mouth.
Oh.
Their skin will shift from warm to ashy or cyanotic. Their extremities will become ice cold as cardiac output plummets, and they will develop profound hypotension.
So if you see cool extremities and a dropping blood pressure, they've transitioned from wet and warm to wet and cold. The pump has given out completely, and they're crashing into cardiogenic shock.
To quantify this chaos, we rely on rapid diagnostics. The ABG's arterial blood gases are critical here. They'll tell a specific story of respiratory progression.
Early on, you see hypoxemia and respiratory alkalosis because the patient is hyperventilating, breathing 40 times a minute, trying to get oxygen, blowing off all their carbon dioxide.
Right. But as the alveoli flood entirely, they tire out. They can no longer move air. The carbon dioxide rapidly builds up, shifting them into hypercapnia and a lethal respiratory acidosis.
We also rely heavily on advanced hemodynamics in the ICU. If the patient has a pulmonary artery catheter, a Swan-Ganz, we look specifically at the pulmonary artery wedge pressure, or POB-UP.
Yes. When we wedge the balloon in the pulmonary artery, it creates a direct pressure window, looking entirely at the left atrial filling pressure. A normal wedge pressure is around 6 to 15 millimeters of mercury.
And in severe ADHF with flash pulmonary edema, You will see a wedge pressure spike up to 25, 30, even 35.
Our entire pharmacological and mechanical goal is to drive that number down before the patient asphyxiates.
Okay, let's look at the clinical priorities for ADPIE here. Assessment. We must instantly recognize the clinical shift. Are they still warm and perfusing, or have they shifted to cold shock?
Diagnosis. The undeniable priorities are impaired gas exchange and massive excess fluid volume.
Planning. Optimize oxygenation immediately and rapidly reduce that pol BP to stop the alveolar flooding.
For implementation, the independent nursing actions are critical, and they must happen before you even reach for a vial of medication. Place the patient in a high Fowler's position, sitting straight up at 90 degrees, and literally dangle their legs over the side of the bed.
Why? I mean, this is pure physics.
Right. Pure physics. Dangling the legs uses gravity to pool venous blood in the lower extremities. This instantly decreases venous return the preload to the right side of the heart. You are mechanically trapping blood in their legs to buy their flooded lungs a few precious seconds of relief.
And evaluation is watching for a decreased respiratory rate. Oxygen saturation's coming up, lung sounds clearing from the top down, and most importantly, massive liters worth of urine output once the drugs hit.
Let's clearly define those priority nursing actions. When this patient rolls in, what is the exact sequence?
The absolute first action. Sit the patient bolt upright, dangle the legs if possible, and apply high-flow oxygen or BiPAP immediately to secure the airway and oxygenation.
The next T action. Administer the stat IV loop diuretics and IV vasodilators as ordered to break the hemodynamic crisis.
Then, insert a Foley catheter. If you're going to aggressively chemically force the kidneys to dump massive amounts of fluid, you must strictly measure hourly urine output to know if your intervention is actually working or if the kidneys have shut down.
Exactly. Let's open the ICU drip setup and look at the medications we use to break this crisis. The absolute first line, given instantly, is IV loop diuretics, usually furosemide. But here is the brilliant physiological trick of IV furosemide. It works before they even pee.
Wait, really? How?
Given intravenously, it causes a mild, immediate systemic venodilation within 5 minutes. This expands the veins, traps blood in the periphery, and decreases preload to the lungs long before the kidneys ever start making urine.
Oh, that's amazing. Then we have the heavy artillery, 5-E nitroglycerin. It's a potent venodilator. It drastically expands the venous system, pulling blood away from the heart and lungs, which rapidly drops the wedge pressure. But there is a huge lethal trap here when titrating this drip, right?
Oh, absolutely. You must titrate IV nitro incredibly carefully. Remember, you are intentionally lowering the blood returning to the heart. If you drop it too far too fast, there won't be enough blood entering the left ventricle to pump out.
So their cardiac output will completely collapse, and they will crash into profound, irreversible hypotension.
Yes. You must monitor their blood pressure every 5 to 10 minutes during the active titration phase.
For the really severe refractory cases, we might escalate to sodium nitroprusside. This is a terrifyingly potent arterial and venous dilator. It drops preload by expanding the veins, and it drops afterload by massively expanding the arteries.
It effectively opens all the floodgates, so the failing heart has zero resistance. But it requires an arterial line for continuous second-to-second blood pressure monitoring.
It does. And the primary exam and clinical trap for nitroprusside is its metabolism. The drug literally breaks down into cyanide in the bloodstream.
Yes, it does. If the infusion rate exceeds 3 micrograms per kilogram per minute for an extended period, or if the patient has any renal impairment, you must rigorously monitor for thiocyanate toxicity.
And the clinical signs are unexplained metabolic acidosis on the ABG, sudden profound confusion, and complaints of tinnitus or ringing in the ears. If you see that, you stop the drip immediately.
Now, what about morphine? This always trips people up, and I know you're going to push back on this.
I have to ask the obvious question. This patient is in flash pulmonary edema. They are literally drowning, breathing 40 times a minute, eyes wide with panic, fighting for every single breath.
Right.
And we are going to push an opiate, a central nervous system depressant that is notorious for causing respiratory depression. Why on earth would we risk taking away their respiratory drive when they need it most?
It is a controversial but historically essential tool, and it perfectly illustrates understanding the why of pharmacology. We do not give morphine for pain in this scenario.
Right.
We give small, careful doses of IV morphine because it acts as a potent vasodilator. It dilates both the pulmonary blood vessels and the systemic venous system, rapidly pulling fluid out of the lungs and reducing both preload and afterload.
And simultaneously, it blunts the sympathetic nervous system's sheer panic response.
Exactly. That anxiety is causing them to burn massive amounts of oxygen they don't have. By calming them, we drastically decrease the myocardial oxygen demand.
But the caution is absolutely justified, right? You must monitor their respiratory rate and depth continuously, because if you suppress their drive too much, they will stop breathing entirely, and you will be intubating them immediately.
Finally, we might need to use inotropes, like dobutamine or milrinone. These are used strictly short-term when the cardiac output is simply too low to sustain life, usually when they are drifting into that wet and cold shock state.
They chemically increase contractility, they force the dying heart muscle to squeeze harder, but they come at a massive, often fatal cost. They drastically increase myocardial oxygen demand. You are literally whipping a dying horse.
That is exactly why we only use them as a temporary bridge. We use them to keep the organs perfusing just long enough for the diuretics to work, or as a bridge to mechanical support.
Speaking of which, if the kidneys simply refuse to respond to the massive doses of Lasix because the heart failure is so severe and renal perfusion is so poor, we escalate to a procedure called ultrafiltration or aquapheresis.
Right.
How does that differ from traditional dialysis?
We put a specialized double-lumen catheter in a large central vein. We pull the blood out, run it through a mechanical filter that physically extracts the plasma water and the sodium, and return the concentrated blood to the patient.
So it can rapidly remove liters of intravascular fluid without causing the severe, crashing hemodynamic instability that traditional hemodialysis often triggers in these fragile patients.
Exactly.
I want to circle back to hemodynamics and respiratory interventions, specifically BiPAP, bilevel positive airway pressure. We slap this tight-fitting mask on a panicking, drowning patient's face. It looks like it's just a way to blast high-concentration oxygen into their lungs. But the physical positive pressure is actually a profound hemodynamic intervention in itself. Walk me through the physics of that.
This is one of the most vital concepts in critical care. BiPAP provides continuous positive pressure into the entire chest cavity. First, on a pulmonary level, that physical pressure literally pushes the fluid out of the alveoli and forces it back into the capillaries, physically recruiting collapsed lung units so gas exchange can happen again.
Wow. Okay.
But second, and most importantly for heart failure, that massive increased intrathoracic pressure physically squeezes the superior and inferior vena cava inside the chest.
And by squeezing those massive veins, it drastically decreases the amount of venous blood returning to the right atrium.
Exactly. So BiPAP treats the deadly hypoxia and mechanically reduces the preload simultaneously. It is an absolute lifesaver for flash pulmonary edema.
But with all this aggressive intervention, the Lasix, the nitro, the BiPAP, we have to talk about fluids and electrolytes. We are chemically forcing the kidneys to dump liters of fluid in a matter of hours.
Which means they are also dumping massive amounts of potassium and magnesium into the urine.
And in a patient whose heart is already ischemic, incredibly stretched, flooded with toxic adrenaline, and incredibly angry, hypokalemia and hypomagnesemia will instantly trigger lethal ventricular arrhythmias like ventricular tachycardia or torsades de pointe.
The ICU nurse must relentlessly monitor the basic metabolic panels, sometimes every 2 hours, and aggressively replace these electrolytes via IV to keep the electrical grid of the heart stable while diuresing the fluid.
The major complication we're trying to prevent here is cardiogenic shock. This is when the patient shifts entirely to that wet-cold profile. The left ventricle is simply too weak to maintain systemic pressure, regardless of the fluid status.
The clinical finding is profound hypotension, altered mental status because the brain is literally starving for blood, and mottled, cold, clammy skin on the extremities.
The action. You immediately stop the vasodilators like nitro, you start the inotropes or vasopressors to clamp down the system and force the heart to beat, you prepare for mechanical circulatory support, and you ensure they're in the highest acuity ICU setting possible.
So, as the nurse watching this patient on the monitor, what are the subtle trends? The patient is getting worse if their hourly urine output drops to 0 despite maxed out continuous diuretic infusions, the kidneys have quit. If their mean arterial pressure, or MAP, steadily falls below 65 millimeters of mercury, meaning end organ perfusion is failing.
Most ominously, if their mental status shifts from wildly anxious and fighting the BiPAP to suddenly quiet, cooperative, and somnolent.
Yes. Novice nurses sometimes think the morphine worked and the patient is relaxing. They are not relaxing. They are retaining massive amounts of CO2, experiencing CO2 narcosis, and are minutes away from respiratory arrest.
That is your absolute trigger for escalation. You call the rapid response team for any sudden, new respiratory distress or the first appearance of pink frothy sputum. But if they go somnolent on the BiPAP and their respiratory acidosis deepens on the follow-up ABG, that is a code situation. You prepare the team for immediate emergent endotracheal intubation.
For differentials, pattern recognition at the door is key. If you see JVD plus pink frothy sputum plus a respiratory rate of 35, you must instantly think acute decompensated heart failure with pulmonary edema. It is the only thing that presents exactly like that.
And the ICU curl here is crucial. This is a trap that even experienced clinicians sometimes fall into. The absolute absence of crackles in the lungs when you listen with your stethoscope does not rule out severe acute decompensated heart failure.
Exactly. This goes back to the lymphatic system. Patients with chronic heart failure have had years to develop massive, dilated, highly efficient lymphatic vessels in their lungs to handle the constant low-grade fluid backup.
So when they acutely decompensate, their wedge pressures might be sky high and their heart might be failing entirely. But because their lymphatics are draining so aggressively, you might not actually hear crackles on auscultation.
The fluid is mostly trapped in the interstitium, not yet bubbling in the alveoli. You have to look at the whole clinical picture, the JVD, the profound orthopnea, the work of breathing, the ABG. Do not let clear lung sounds trick you into thinking the heart is fine.
Let's run the intensivist thinking for Section 2, the acute crisis, the problem, alveolar flooding and loss of gas exchange.
The failing physiology. Sky-high pulmonary artery wedge pressure, forcefully pushing fluid through the capillary beds into the lungs.
The immediate threat, asphyxiation. The patient is drowning in their own plasma.
The intervention. High Fowler's positioning, BiPAP to push the fluid back, IV nitroglycerin to drop preload, and 5E Lasix to clear the volume.
And the reassessment, monitoring for clearing ABGs, improved oxygenation, and massive hourly urine output.
Perfect. So if an intensivist is mentally reviewing this acute phase, what are the 5 absolutely essential takeaways? First, the core pathophysiology is acutely elevated pulmonary venous pressure, forcing fluid into the alveoli, preventing all gas exchange.
Second, the key assessment finding that defines this crisis is profound JVD, extreme tachypnea, and pink frothy sputum.
Third, the most dangerous complication is complete respiratory failure and crashing into cardiogenic shock, the deadly wet-cold profile.
Fourth, the priority independent nursing action is immediately placing them in a high Fowler's position with legs dangling and applying BiPAP.
Fifth, the most important pharmacological treatment is the 1-2 punch of 5E loop diuretics and 5E vasodilators like nitroglycerin.
And if we distill this chaotic emergency into a one-sentence clinical picture,
it's an acutely dysmaic, extremely anxious patient sitting bolt upright on the edge of the bed, utilizing all accessory muscles to breathe and coughing up pink-tinged foam.
And the critical trigger for the nurse managing the drips.
If you see a sudden drop in blood pressure during a nitroprusside or nitroglycerin infusion, think vasodilation-induced hypotension and immediately decrease or pause the drip rate before they arrest.
But that raises the ultimate question. We've talked about the pills, we've talked about the drips, we've talked about the masks. What happens when we max out the drip rates? What happens when the kidneys ignore the Lasix, the BiPAP can't overcome the hydrostatic pressure, and the inotropes are just triggering lethal ventricular arrhythmias because the heart is too far gone?
Well, that brings us to our final, most extreme frontier. Extremis. Mechanical circulatory support and end-stage failure. We are entering stage D, heart failure.
The 80-20 overview for stage D is bleak. I mean, the texts are very clear. This stage carries a mortality rate that is worse than most advanced metastatic cancers. We have completely exhausted conventional pharmacology.
The myocardium itself is simply too damaged, too fibrotic, and too weak to sustain human life. We must rely on advanced mechanical devices to literally physically take over the work of pumping the blood.
The pathophysiology here is total pump failure. The myocardium cannot eject blood against the systemic vascular resistance. As a result, end organs, the brain, the kidneys, the liver, the gut, are actively beginning to die from profound lack of perfusion.
To save the patient, we have to use machines to artificially lower the afterload to almost nothing and mechanically augment the coronary perfusion just to keep the remaining heart tissue alive.
Because of this, our assessment drastically shifts. We are no longer just assessing the failing heart. We are primarily assessing for catastrophic device complications and distal tissue perfusion.
Exactly. For example, if a patient has an intra-aortic balloon pump, or IABP, inserted through their femoral artery in the groin, the nurse must continually, obsessively assess the radial pulses in their arms, listen for bowel sounds, and strictly measure urine output. Because this device is massive, and if it moves an inch, it can block vital arteries.
Right. For diagnostics, we rely entirely on advanced waveforms, specifically the arterial line. The IABP console is a massive computer that literally reads the patient's continuous arterial pressure wave to know exactly when to inflate and deflate the balloon. It is specifically searching for a tiny blip on the waveform called the dicrotic notch.
What exactly is the dicrotic notch physiologically?
The dicrotic notch represents the exact millisecond the aortic valve snaps shut, signaling the end of systole and the very beginning of diastole. The computer uses that notch to time the balloon.
It must inflate perfectly in sync with that closure, because if the timing is off by a fraction of a second...
It inflates while the heart is pumping.
Exactly, and it will destroy the left ventricle.
Let's talk about the clinical priorities for a patient with an IABP assessment. You absolutely must take a marker and check and mark the peripheral pulses in both legs, the dorsalis pedis and posterior tibial, before the surgeon inserts the huge catheter into the femoral artery. You need a rock-solid baseline to know if you've lost blood flow to the leg afterward.
Diagnosis: profoundly decreased tissue perfusion and an immense life-threatening risk for bleeding and infection.
Planning: maintain precise pump timing on the console and perfectly immobilize the cannulated leg.
Implementation: you must keep the head of the bed lower than 45 degrees at all times. Do not, under any circumstances, let the patient flex or bend the hip of the leg where the massive catheter is inserted.
Because if they bend their leg, they will kink the stiff catheter, instantly rupture the balloon inside their aorta, or literally tear their femoral artery wide open and bleed to death internally in minutes.
Yes. Evaluation is looking at the monitor and seeing an increased mean arterial pressure, seeing their mentation improve as the brain gets blood, and feeling warm extremities, indicating the machine is successfully overriding the feeling heart and perfusing the body.
Priority nursing actions in this extremis phase. First, verify the proper 1.1 assist ratio and timing on the console. That means 1 balloon inflation for every 1 patient heartbeat.
Next, perform intense neurovascular checks of that cannulated leg every single hour. Color, motion, sensation, temperature, and Doppler pulses.
Then assess the console itself for mechanical complications, specifically looking and listening for gas leak alarms.
The medications in this mechanical phase change drastically. We must use mandatory anticoagulants, almost always a continuous heparin infusion.
Because the body is brilliant at recognizing foreign objects. Whenever you put a massive piece of plastic like a balloon or a titanium VAD into the central bloodstream, the body immediately tries to clot it off. The heparin stops that.
And if this mechanical support buys them enough time to get a heart transplant, we switch them to lifelong immunosuppressant drugs like corticosteroids, tacrolimus, mycophenolate, mofetil to intentionally paralyze their immune system so it doesn't attack and reject the new organ.
Let's clearly define these procedures for the listener. The IABP is a long, sausage-shaped polyurethane balloon sitting in the descending aorta, inflating and deflating. A VAD ventricular assist device is an actual mechanical titanium pump, usually implanted in the chest, that physically shunts blood directly from the failing left ventricle, bypasses the diseased heart muscle entirely, and blasts it continuously into the aorta.
And then heart transplant, which can be a biatrial approach where they leave part of the recipient's original atria intact to preserve the SA node, or bicaval. And the way they monitor for rejection post-transplant is wild.
They thread a catheter through the jugular vein in the neck, down into the newly transplanted right ventricle, and use tiny jaws to literally snip off microscopic pieces of the new heart muscle for biopsy every week. It's sci-fi level medicine.
It truly is. But I want to delve deeply into the hemodynamics of the IABP because the core concept of counterpulsation is one of the most brilliant mechanical interventions in human history.
Right, and I have to push back on this concept.
Yeah.
Because when you first learn it, it sounds completely dangerously backward. Let me get this straight. You have a patient whose heart is incredibly weak and can barely pump blood forward to the body.
Okay.
So the surgeon threads a massive, thick balloon into the main pipe, leaving the heart, the aorta, and inflates it. Doesn't inflating a giant balloon in the aorta physically plug the pipe? How on earth does intentionally blocking blood flow save a heart that is already failing to pump?
It is entirely about the precise timing of the inflation. The balloon does not inflate when the heart is squeezing. The balloon inflates only during diastole, when the heart muscle is resting and the aortic valve is tightly closed.
Okay, so the valve is shut.
Right. By inflating this massive balloon in the descending aorta during diastole, it physically displaces a huge volume of blood, pushing it backward, retrograde, toward the closed aortic valve. That pressurized blood hits the closed valve and has nowhere else to go but directly into the coronary arteries. It massively, forcefully augments oxygen delivery to the starving, dying heart muscle. It feeds the heart.
Okay, so diastolic inflation feeds the heart. But what about getting the blood out to the body?
Well then, a split second before systole begins, a millisecond before the left ventricle attempts to squeeze the computer instantly, rapidly deflates the balloon.
Creating a vacuum.
Exactly. This massive sudden deflation creates a literal vacuum effect inside the aorta. It drastically drops the pressure in the aorta to near zero. So when the weak left ventricle finally opens the aortic valve, it meets zero resistance.
The vacuum literally sucks the blood out of the weak left ventricle, massively reducing the afterload. The failing heart barely has to expend any energy to empty itself.
It's called counterpulsation because the balloon's action is exactly opposite to the heart's action. Diastolic inflation feeds the muscle. Systolic deflation unloads the muscle.
It's pure genius. But managing a patient hooked to this machine requires intense attention to the fluids and electrolytes, particularly the hematologic system. The physical, violent, mechanical pumping action of the balloon, or the high-speed impeller inside a VAD, physically smashes and destroys red blood cells and platelets as they pass by.
You will see severe thrombocytopenia and hemolytic anemia just from the machine pulverizing the blood components.
Which leads us to the terrifying complications of mechanical support. Let's talk about IABP migration. The balloon is sitting perfectly positioned in the descending aorta, but if the patient moves or the catheter slips, and the balloon migrates upward toward the aortic arch, it blocks the left subclavian artery.
The patient's left arm will suddenly turn cold, pale, and you will lose the left radial pulse entirely. Conversely, if it slips downward, deeper into the aorta, it occludes the renal and mesenteric arteries branching off to the organs.
The patient's hourly urine output will instantly drop to zero, and they will lose all bowel sounds as their gut becomes ischemic and begins to die.
And for the patients who survive to get a transplant, the biggest complication in the first year isn't always organ rejection, it's infection. It is the leading cause of death because we have intentionally destroyed their immune system with powerful drugs. A simple common cold can turn into lethal sepsis in a matter of days.
So, as the nurse managing the console at 3 a.m., the patient is getting worse
If you hear repeated blaring alarms for gas loss on the IABP console, the balloon is filled with helium, specifically because helium is a very light, incredibly fast-moving gas that won't dissolve dangerously if a tiny leak occurs.
But if the console says it's losing significant gas, or God forbid, you look at the clear helium tubing connecting the patient to the machine, and you see actual bright red blood backing up into it.
The balloon has catastrophically ruptured inside the patient's aorta.
Which is an absolute code-level escalation emergency. If you see blood in the helium tubing, you stop the pump immediately, you notify the provider, you prepare the patient for emergent surgical removal of the balloon.
Because if you keep the console pumping a ruptured balloon, it will pump lethal pressurized helium gas emboli directly into their central bloodstream, causing massive, unrecoverable strokes or instant death.
Differentials for this extremist stage require a very specific mindset. If you see a sudden drop in urine output in a patient with an IABP, do not just assume their heart failure is worsening and they need more Lasix.
You must immediately think downward balloon migration, including the renal arteries. You check the catheter position mark at the insertion site on the leg to see if it moved.
An essential ICU pearl here, something that shows up in practice and exams all the time. You can never just turn off an IABP console and leave the catheter sitting dormant in the patient's aorta.
Never. Even if the patient is fully recovered, their heart is beating perfectly on its own, and you are just waiting for the vascular surgeon to come pull the catheter out, the machine must continue pumping at a lower weaning ratio, like 1 inflation for every 3 or 4 heartbeats.
If you turn the console completely off, the stagnant blood pooling around this massive piece of foreign plastic in the aorta will instantly form a catastrophic, life-ending clot that will shower emboli to the entire lower body.
Let's apply our intensivist thinking to stage D, the problem. Profound cardiogenic shock.
The failing physiology. Absolutely no forward flow from the ventricles. The pump has completely failed.
The immediate threat. multi-organ systemic end-organ death from lack of perfusion.
The intervention, IABP counterpulsation, VAD insertion, or emergent listing for transplant.
The reassessment. Looking for aortic pressure augmentation on the monitor, return of end organ function like urine output, and eventually readiness to wean from the device.
To summarize the absolute extremes of our care, if a clinician is reviewing stage D failure, what are the 5 absolute core takeaways? First, the core pathophysiology is that the heart requires mechanical augmentation to maintain coronary perfusion and systemic output because the native muscle has failed entirely.
Second, the key assessment finding is constantly checking distal pulses, hourly urine output, and left arm perfusion to ensure the IABP hasn't migrated and blocked an artery.
Third, the most dangerous catastrophic complication is IABP, balloon rupture, or migration.
Fourth, the priority nursing action is to perfectly immobilize that cannulated leg and keep the head of the bed lower than 45 degrees to prevent catheter kinking or arterial tearing.
Fifth, the most important treatment concept is counterpulsation diastolic inflation to forcefully feed the heart and systolic deflation to create a vacuum and empty it.
The one-sentence clinical picture. A critically ill, deeply sedated patient in profound cardiogenic shock, lying flat in bed, relying entirely on a loud, rhythmic arterial console to mechanically dictate their blood flow and keep them alive.
And the life or death trier. If you see blood in the clear IABP tubing, think balloon rupture and immediately stop the pump to prevent a fatal helium embolus.
That brings us through the entire spectrum of this disease. We've traced the pathology from the very beginning to the absolute limit of modern medical technology.
We really have. We've gone from the insidious, invisible stretching of the microscopic muscle fibers and the toxic bath of chronic hormones to the chaotic, drowning terror of flooded alveoli in the emergency room, and finally, to the cold, mechanical marvels of counterpulsation, keeping a human alive when their own organs have surrendered.
And thinking like an intensivist means you aren't just reacting to these stages as they happen, you are anticipating the next failure before it occurs. When you see the unexplained tachycardia on the floor, you are anticipating the pulmonary edema. When you see the BiPAP failing to improve the ABG, you are anticipating the cardiogenic shock and prepping the room for the IABP. You are always one step ahead of the failing physiology.
But I want to leave you with a final, lingering thought. Because out in the real world, standing at the bedside at 2 in the morning, the hardest decisions in the ICU aren't always about which medication to push, or calculating nitro drip rates, or managing balloon timing. It's about what happens when the mechanical interventions work too well, but the patient's body fails elsewhere. What happens when the machine outlives the human?
The profound ethical dilemmas of critical care.
Right. Straight from the case studies in the literature. Consider the scenario of a patient, let's call an MT. He's 60 years old, waiting for a heart transplant, currently bridging on a ventricular assist device in the ICU. The titanium VAD is flawlessly pumping his blood. His heart failure is technically managed.
Okay.
But he suffers a massive stroke, which is a known, devastating complication of the device throwing a clot. The stroke leaves him entirely paralyzed on his right side and permanently tethered to a mechanical ventilator because he can no longer protect his airway.
He's physically trapped.
Completely. He has no written advance directive on file. But his wife and daughter are sobbing at the bedside, and they tell the medical team that he stated on multiple occasions before this happened that he would never, ever want to live like this, entirely dependent on machines, stripped of his independence and dignity.
This happens all the time.
And here's where the bedside reality hits you as a nurse. When you go to suction his endotracheal tube to clear his secretions, he deliberately turns his head away from you. He bites down hard on the plastic tube. He glares at you. He is fighting the machine.
He is communicating in the only physical way he possibly can.
But to legally and ethically withdraw life support, to turn off the ventilator and power down the VAD, the medical team has to definitively prove he has decisional capacity. The legal threshold for competence in that moment can sometimes be as simple as answering yes or no by shaking his head. So, as the ICU nurse standing at that bedside, when your patient is physically tethered to a machine that forces his blood to circulate, but his mind is trapped in a paralyzed, failing body, how do you navigate that agonizing ethical responsibility?
How do you advocate for proving his decisional capacity so his family can honor his wishes and withdraw support?
Right. It's a haunting reminder that mastering the complex physiology, memorizing the pharmacology, and running the advanced machines is only half the job. In the ICU, the absolute hardest decisions are looking beyond the monitor, seeing the human being, and knowing when it's finally time to stop fighting the inevitable.
A profound, sobering reality of critical care.
Thank you for joining us on this incredibly intense journey today. Take this bedside logic, this intensivist framework, and apply it to your next shift. Keep anticipating the next failure. Trust your understanding of the physiology and always look beyond the machines to the human in the bed. See you next time on The Deep Dive.